Hi, this is Dr. Vivek Kaul from the University of Rochester Medical Center, and I'm very pleased to present this GIE author interview series video on behalf of all my co-authors for our paper, The Safety and Efficacy of a Novel Powered Endoscopic Debridement Tissue Resection Device for the Management of Difficult-to-Remove Colon and Foregut Lesions, the first USA multicenter experience. The field of endoscopic resection has undergone significant advances in the last 2 decades. The objective of our study was to evaluate the technical feasibility, safety, and efficacy of a novel endorotor tissue resection device. This study was conducted at 4 high-volume therapeutic endoscopy referral centers in the United States: Thomas Jefferson University Hospital in Philadelphia, Silver Cross Hospital in Chicago, Illinois, Geisinger Medical Center in Dansville, Pennsylvania, and at the University of Rochester Medical Center. Before we get into the study details, I would like to talk a little bit about the endorotor device itself and the technique of endoluminal resection using the non-thermal powered endoscopic debridement tissue resection device. The endorotor equipment consists of a main console as well as the endorotor catheter itself. The main endorotor console is mounted on an IV pole-like structure with a separate suction apparatus at the bottom. The suction and rotation of the cutting blade catheter are controlled by independent foot pedals that are part of the equipment. There is also a dedicated tissue trapping device. The tissue fragments that are retrieved from the endorotor resection are relatively fragmented, but they retain the histological architecture. While they are not helpful in terms of staging a lesion, the tissue resection specimens do give a representative sample of the pathology at hand and answers the basic question of whether there is any residual dysplasia or carcinoma in the specimen or whether it's more benign tissue. The endorotor catheter, which is depicted in this next graphic, consists of an outer sheath and an inner rotating cutting blade which can be adjusted to a variable speed between 1000 and 1700 RPM. If you look closely at the graphic of the endorotor catheter, there is a solid black line that indicates that the cutting blade is at 180 degrees direction opposite to the line itself. The interrupted black line at the tip of the catheter indicates that the cutting blade is at a 90-degree orientation. These markings enable the endoscopist to be confident to know where the cutting blade is at a particular time and its location vis-a-vis to the target lesion. The technique of powered endoscopic debridement using the endorotor device involves initial injection of a submucosal solution of saline, epinephrine, and methylene blue, followed by the tissue resection. Majority of these lesions, as in our study, have significant fibrosis and scar tissue at the base, or have had a prior attempt at cautery-based resection. This is where the endorotor device is particularly helpful because it's a non-thermal tissue resection device and particularly useful and efficient at removing scarred tissue. Now that I have discussed the endorotor device itself and the technique of powered endoscopic debridement, I would like to show a couple of video-based cases where this technique and this device was found exceptionally useful in the management of these lesions. This first video demonstrates the use of the endorotor device and the PED technique in the management of a patient with dysplastic refractory Barrett's. As you can see, after the initial injection, endorotor resection is performed in a stepwise fashion with resection of the mucosal and submucosal layers until the entire visible dysplastic Barrett segment is resected. This second video demonstrates a colonic adenoma that had previously undergone an attempt at EMR at an outside center. Due to the fibrotic and scarred base, that attempt was unsuccessful. After initial submucosal injection, endorotor resection was carried out in a stepwise fashion with complete resection of this lesion as demonstrated in this video. Now let's talk a little bit about our study. This was an IRB-approved multicenter study conducted at 4 institutions, which involved 34 patients and the resection of 41 lesions. This study was conducted between 2018 and 2019. Table 1 shows the patient demographics. The mean patient age was 72 years and majority were male. In addition, histopathology of the lesions as well as adverse events were recorded. The most common indications for PED in our study included recurrent, residual or persistent colonic adenomas in about 53% of patients, and residual or recurrent Barrett's with or without dysplasia in about 24% of patients. The remaining patients had recurrent or residual rectal or duodenal lesions that were also deemed to be difficult to resect at the prior endoscopic sessions. Most patients in our study had had a prior attempt at endoscopic resection, about 85% of patients. So this was a highly enriched population where the target lesions were difficult to remove and technically challenging to start with. Overall, the endorotor resection procedure using the PED technique was very safe and performed on an outpatient basis, typically with general anesthesia, but not always. There were 10 patients who had intraprocedural bleeding that was all managed successfully endoscopically at the time of the PED procedure. 3 patients had adverse events recorded during the study. 1 patient had mild chest pain post-procedure, and 2 patients had presented with delayed bleeding post-PED resection, both of whom were managed successfully endoscopically. There were no perforations or deaths recorded as part of the study. The technical success rate of our study was 98%, in that 40 of 41 lesions were completely removed at the index PED procedure. The clinical success rate of our study was 80%, and this was calculated based on the histological findings on follow-up endoscopy. In conclusion, we have seen a novel endoscopic tissue resection device, the endorotor, and how it is used to perform non-thermal powered endoscopic tissue resection in difficult to remove colonic and foregut lesions. I'm very excited about this technology and particularly excited that it was published in Gastrointestinal Endoscopy. I want to again thank all my co-authors, without whose effort this paper would not be possible. I think this device and technique will benefit from further prospective studies and trials, and its role will be further clarified in the years to come. Thank you very much.